Okay, let's go ahead and get started. Lecture 18, Transfusion Practices. We're going to talk about emergency release in the event that you don't have a specimen on your patient, what to do in those situations. We're also going to briefly talk about some neonatal transfusions, but we're really going to hit on the neonates when we get to the mom and baby section. All right. All right, so when to transfuse red cells? All right, so we know the purpose of transfusing red cells is really for oxygen carrying capabilities. We want to make sure that that recipient's ability to maintain an adequate supply of oxygen, all right? And so red cell transfusions can give them more hemoglobin to improve that oxygen carrying capability. The oxygen content of the blood, this is kind of taking it back to hematology, is dependent upon the hemoglobin concentration, because you guys remember that hemoglobin molecule is what is going to bind to the oxygen, okay? And then the percent saturation of hemoglobin, and then the quantity of oxygen dissolved in the plasma. So this kind of goes back to your oxygen dissociation curve. You guys remember we talked about that in hematology as well, all right? So your red cells normally release about 25% of oxygen, again, that oxygen dissociation curve. There are some times you have increased demands of oxygen or decreased supply of oxygen, and that would just result when there is greater release of oxygen from that hemoglobin molecule. Again, that would be indicated by that right shift in the dissociation curve. However, hemoglobin determination should not be the sole determining factor to warrant a transfusion, right? You also want to look at their pulse ox percent, how much oxygen do they have. Maybe a transfusion is not the best therapy for them. However, maybe a oxygen delivery through the cannula might be a better option rather than transfusing red cells. So you kind of have to look at not only the hemoglobin, but the state of your patient as well. And what happens when you have decreased oxygen causes your body to have anaerobic metabolism. And we all know that would increase lactic acid, cause your body could go into acidosis. And when you go into acidosis, you could have impaired cardiac function, decreased perfusion, so the amount of cells that are traveling to the tissues, which could lead to tissue ischemia or tissue hypoxia, all right? And then again, should consider alternative rather than transfusion, such as oxygen. All right, you guys remember, we talked about this in a previous lecture, 1 unit of blood will increase your patient's hemoglobin by 1 gram per deciliter. It will increase the hematocrit by 3%, all right? That should be the outcome of receiving 1 unit of red cells. And then this chart is actually in your lecture manual, when to transfuse. So if your patient presents with anemia or active bleeding, notice that you always want to assess your O2 levels, all right, before you give a transfusion. And also, we always want to think about if your patient is actively bleeding, perhaps if the bleeding is severe enough, we not only want to give red cells, but we also might want to give them some volume replacement as well. So plasma and plasma FFP or platelets might be warranted as well if their platelet count drops too. All right, so the tag requirements. So if your patient does need a transfusion, you set up a unit for them. Their blood bank is very particular. Everything has to be labeled appropriately, and you will double and triple check yourself, okay? And so this is what a typical donor unit is going to look like. Once it's cross-matched on a patient, you are going to add that additional patient information as well. Some blood banks have special printers that will print tags that are attached to this unit. All right, so that tag must have the patient's full name and ID number. Usually it's also going to have the date of birth. It's going to have the exact type of blood product. Is it red cells? Has it been irradiated? Has it been washed? So the type of product and any attributes that are associated with that product. The unique donor number, all right? And so in this example, here's your donor number right here. Notice in that barcode. Within that barcode, that donor number is embedded with the collection facility, the unit number, and then also the expiration date, all right? So all of that should be preloaded into your blood product management system. And then once it's attached to that patient and the status in your blood product management changes from issued to transfused, this unit will always be attached to that patient. It is a permanent record, okay? And then also on that transfusion slip, your interpretation of the cross-match, was it compatible, or did pathology approve to give least incompatible? Maybe your patient has a warm auto. That would be an example where you would give least incompatible. Yes, ma'am.
So say we have FFP and then it just becomes thawed plasma.
Mm-hmm.
If the barcode is for that specific expiration date, where would we mark to change that?
So that's a good question. So when you receive that product from your donor facility, it's going to be labeled as fresh frozen plasma, right? It's going to go into your inventory as frozen. When you pull it out of the freezer and thaw it, you have to tell your computer that you have changed this product from frozen to thawed plasma. So it will then have a different product code. So your inventory system will know that. Anytime you change the status of a unit, has to be programmed into your computer. So, and then that will change the expiration date as well. And then the testing technology, the testing technologist information must be attached to that as well. And so here's an example of what a cross-match unit tag might look like. Notice that you have your patient information. Notice on there too that you actually have your patient blood group and your unit blood group. If your patient is A positive and you are giving them an O positive, sometimes that will throw nursing off, all right? They might not realize, hey, this unit is different from my patient's ABO type. Is this a issue? Is this a problem? You will filter some calls like that. They'll say, oh, my patient is A, but you have an O unit here, all right? And so you just have to explain to them that it's a compatible unit, especially if they have antibodies. Sometimes if they have antibodies, and to get antigen negative blood, we will go outside of their type specific blood. Does that make sense? So that's the most common sense you'll see that, but you'll get calls from nursing, especially on platelets. If we're given an A patient a B platelet, remember on platelets, we typically don't honor the type, all right? We try to, but sometimes given our inventory of platelets, we just give them whatever we have in our stock, all right? Nope, you decide that. Yes, that is on you. The only time pathology is involved is if you have a patient with a warm auto and you are given least incompatible blood, they need to be aware of that. Anytime you have a male patient that's involved in a trauma and he is RH negative and you're going to give him RH positive blood, that requires pathology approval. But everything else, pretty much you make that decision. So yeah, you'll be determining what type of blood to give your patient, what type of plasma, platelets, cryo. You'll be determining that on a daily basis. So it's very important. And then notice here's your component. It says packed cells. It even says that it has additive added. So that would be your adsol. And it has your unit number, the volume, your expiration date. And then it would have your cross-match result right here, compatible or incompatible, all right? Now, if you were to give least incompatible units for a patient that had a warm auto, that will also cause some concerns on the nursing side. They're gonna be like, this says this unit is not incompatible. However, you have probably already been in contact with them. They probably are aware of the patient's immune status. They have some type of autoimmune hemolytic anemia, warm auto antibody going on, and they are aware of that, all right? In the event that you attach any special requirements for that transfusion, such as use of a blood warmer, it will also, you'll have a note that will appear on here, and you'll also put a little very brightly color-coded sticker on the unit that lets nursing staff know a blood warmer is recommended for transfusion. Okay. And then notice here is your tech information, has the date that the cross-match was performed, has the initials of the tech, and it even has what order number it was on. That's your accession number right there. All right.
So we learned about the delivery times of over 4 hours or
Yep.
something like that. Will we be held responsible for that, or is that on their sheets?
That's on, so typically that's on their side. The only thing you will be concerned of is, let's say they send down a request for blood to be sent up to be transfused to the patient. Something happens when that unit gets up to the patient bedside. Let's say they take vitals and maybe the patient's temperature is greater than 99.5. Well, then they're not going to transfuse that patient. They're going to send that unit back down to you. If it has been greater than 30 minutes from the time that unit left blood bank, it has been out of temperature too long, it has to be discarded. All right, and that's just the risk of bacterial contamination. You will have, this will happen to you guys too. You'll have nurses call and say, hey, you know what, the clinicians decided to wait to transfuse this patient. We're gonna wait an hour, or maybe the patient got taken for a CT. He's not in his room right now. We're gonna transfuse when he gets back. I'm just gonna put this unit in our refrigerator up here. Okay, huge no-no. Why would that be a no-no? Their temperature of that refrigerator is not monitored. All right, so you don't know if it's at 4 degrees or 8 degrees. All right, and remember, we have to be within that 1 to 6 degree range. Okay, so if a nurse calls you and say, I'm just gonna store it in our refrigerator up here until he gets back from CT, no, send it back to me so I can make sure it hasn't been out longer than 30 minutes, and then I can monitor the storage temperature. Okay, that's a huge deal. So it cannot be away from blood bank greater than 30 minutes if it's not going to be transfused. Okay, and then once the nurses actually proceed with the transfusion procedure, they have a total of 4 hours to get it transfused. Okay. And notice also on this transfusion slip, you'll notice this area over here. This is where the patient vitals are going to be recorded. So before they start the transfusion, they're going to take your patient vitals, and then 15 minutes after the start of the transfusion, they're going to retake the vitals just to make sure. If a transfusion reaction were to occur, and it's a severe one, it's most likely going to occur immediately, all right? And then so every 15 to 30 minutes during that transfusion, the nurses will continue to check your patient vitals, all right? So that nurse is pretty much in there with the transfusion while it's going on. Yes, ma'am.
So back to the timing thing, will we need to ask them how long they've had this blood put out? Or?
I mean, typically they know that. The only problem will occur if this will happen. You will have, some physicians will want to extend the time of that transfusion, like they want to do a really slow drip. If they do that, what blood bank can do is we can half the unit. So we will give them, we will divide a red cell unit in half. They can have the half, and then they can do a slow drip to deliver that over the 4 hours recommended time. And then when they're ready for the other half, they can send it as well. And it just depends on how slow of a transfusion they want to do. We have done that at UAMS before. We've split the unit in half for them if they want to extend the transfusion time.
How exactly would you do that with the unit of blood?
So you would use that sterile docking system that I showed you and connect your mother unit to a satellite bag. And then you would have your satellite bag on a scale, hang your parent unit up, and you would know your beginning volume. And then you would put half of it in your satellite bag, keeping half of it in your mother bag. And then, so then in your computer system, you could, there's a function you can split the unit. And so then it has 2 parts. And so usually it's like an A and a B. And so then you would issue A out to them. All right. And then when they're ready, they get the B part.
And that would still be considered closed system?
It is still considered closed system because you use the sterile docking. So you're using heat and that the little wafer that cuts the tubing and then seals it back together. So that is considered a closed system. Yeah. So that does not change the expiration time. So if you guys, this is probably a, your transfusion slips are always going to be in duplicate. So blood bank will keep one of this, and then this will also, of course, be attached to the unit to go up to the floor. This is kind of an outdated one. Most oftentimes what's going to happen is you're going to have these little patient stickers. Your transfusion slips are going to have these stickers. And so when you send the unit up, the transfusion slip is usually going to be attached to the unit through this little hole right here. We kind of, the little plastic tags, you attach it here, and then your transfusion slip has a sticker, so you peel that sticker off and attach it to the unit. So now both the unit and the tag are labeled with that patient information. All right. And so I've told you guys this before, but all information is going to be reviewed before that unit leaves the blood bank. 2 techs have to be involved in the sign out procedure. Number 1, you're confirming patient information, name and medical record number. I always like to check date of birth too, but you just have to have 2 unique identifiers. And then patient ABO, and then your unit ABO. All right, you want to make sure that's compatible. Any attributes that that patient requires, you want to make sure that that's honored as well. So if your patient has an antibody, you want to make sure that the unit is antigen negative. That's one thing you'll check. If that patient has any type of diagnosis that requires irradiated products, you want to make sure irradiated products are given, and any other attributes that might be needed. All right, so that's the time that you double check that as well. And your expiration date. All right, your inventory system won't let you send out any expired units, but just make sure that your expiration date is in the future. That's another thing too. Product management is real big in blood bank right now. So if you have some red cells that, let's say, are going to expire today or tomorrow, and you send them up to the floor, that will alarm nurses too, because it's close to the expiration date. They're like, is this unit even still good? And just, you have to tell them that yes, it is. That's the designated expiration time. And especially if let's say you have a unit in your stock that expires today at midnight. All right, so the day it expires is always at midnight. So it expires at 11:59 p.m. So if you send a unit out today that expires tonight at 11:59 p.m., that can really throw them off, and they're going to call you. All right. And then you want to visually inspect that unit too. You don't want any visible hemolysis in your red cell unit. You don't want your plasma or platelets to be real turbid. That could indicate bacterial contamination. I have seen plasma be a bright green coloration, and that just means that your patient was probably on some type of oral contraceptives. That can make your plasma green. So there's some color variation in your plasma, but you don't want it to be so turbid or cloudy or any type of precipitate forming in it. That could indicate bacterial contamination.
It would still be fine if it was green, right?
Yeah, it's fine if it's green. Yeah, that just indicates that the donor was on some type of medication, acceptable medication. Another thing, and I think I've talked to you guys about this on those donor units, and does this one have this is not included in the picture. The segments. Anytime before you issue a unit for transfusion, you want to make sure that you have segments on that unit. All right, and that's just because those segments have numbers, a series of numbers and letters that are associated with that unit. We will keep those in blood bank for 7 days. And the reason for that is if that patient has a transfusion reaction to that unit, we have to repeat our testing, maybe do a DAT on that donor. All right, so that's how we will access those red cells. We have to have those segments, okay? And usually, and I will show you guys when we go tour the blood bank, usually we call those pilot tubes. So whenever we receive red cells from our donor center, we pull off segments, put them in the pilot tubes, and they're stored with the unit until they're issued out to the patient. And then we take those pilot tubes and put them in a specific transfused rack. And then those are stored in the refrigerator for 7 days, okay? Sarah has a question. So Sarah asked, as long as they start infusing prior to the expiration date. So that's right. So if your unit expired at 11:15 or 11:59 and they started at 10 p.m., that's still good. So as long as it's being transfused before that expiration time. All right, so 2 technologists before that unit can be issued. And then at the patient bedside, it's also going to involve 2 nurses, okay? And they're actually checking the patient identification. So they're actually looking at your patient's armband. Very important, if you were ever involved in training nurses on how to transfuse, that armband is attached to the patient, around their wrist, around their ankle, somewhere. I have seen armbands be placed on the bed rail. No, don't do that, okay? And if you were ever involved in the transfusion process, you cannot go by the room label either, not by the name on the room, okay? It has to physically be on the patient somewhere, right? I've seen it around their ankle before too, okay? There was a question over here? No? Okay. And then, so as you guys can see from your transfusion slip, the vitals are recorded on there. That becomes a permanent record. Blood bank is going to keep their copy, and then the nursing staff will put this in the patient's chart. With the electronic medical records now, this is probably scanned in to their digital file, right? It's considered a permanent record. And the reason for that is because if there was ever a look back, let's say the donor center says, oh, this unit popped up hepatitis C, this donor is now hepatitis C, we have to contact all of his previous donations and let recipients know that that donor has now been tested hepatitis C positive, okay? Or HIV, or Zika, or whatever infectious disease it might be, okay? That's why it's considered a permanent record. And then again, if that blood is not transfused within 30 minutes, so if that transfusion is not started within 30 minutes, they need to return it to blood bank. Blood bank cannot put it back in their inventory. It will be discarded, all right? That just means it's been outside of the temperature range, greater than 30 minutes. We cannot accept it back into our inventory, okay? All right, and you guys know blood should be infused within 4 hours, and that's just to prevent bacterial growth. This it mentions if they expect it to be greater than 4 hours, we can split that unit, all right, into 2 parts. So what the nursing staff is going to do during the transfusion, they're going to use a 19-gauge sterile needle. Sometimes the patients might already have an IV. They can just use the already established IV. Remember, when we are transfusing, some of these units might have already been leukoreduced during the collection process. However, in order to catch any type of debris that might be in the unit, any type of fibrin strands that might have formed during the refrigeration storage, we want to use that filter to catch all of that debris, all right? So that's why it's usually about 170 nanometers filter that will, I'll show you a picture. It's attached underneath your unit. So when they hang the unit, it's going to travel through a filter, and then it's going to go through the drip, and then it'll go through their tubing into the IV. Right, and remember, we want to dilute our products with 0.9% saline. That is the only thing the nursing staff can use to dilute their transfusions, okay? We don't want to use Ringer's lactate or another colloid substance. Ringer's lactate has calcium in it, so we don't want to activate the coagulation cascade. And then another one might cause rouleau, all right? So we don't want that to happen either. All right, so this is what your blood infusion accessories are going to look like. Here at UAMS, we had the Y tubing. This is what we had, so we would send this up with all of our units. So we provided the tubing for them. Other hospitals might not provide that. They might have it on their stockroom on their floor. All right, but we sent this up with all of our units. And so it's just a Y tubing. Notice it has 2 spikes on there. So this is the spike. It has a plastic cover on there to protect the spike. So one spike will go into your unit, whether it be red cells, platelets, plasma. The other spike will go into a bag of 0.9% saline. Okay, that's why it's called a Y tubing. And then those are going to come together. And then here's your drip. So it combines the saline and your red cells. And then the remaining tubing goes to your patient. And so this is kind of what it looks like. So here's your donor unit. Here's your saline. Both of these will have roller clamps. I don't know if any of you guys have experience using tubing or anything, but these have roller clamps. So if you wanted to stop the flow, you could push that roller clamp all the way and it would stop the flow of blood or saline. So both of those have roller clamps. Here is your filter, right? Your 170 nanometer filter. And then this will go to your patient, right, through their IV access. And then this is a IV bag of saline if you guys have never seen that before. Some of you guys might have had a family member that's in the hospital. You know, they always have an IV pole and it usually has a little keypad on it and the tubing can connect through there. That is an electro way to control the flow. So they can set the drip rate to control how fast, how slow they want it to go. Most places are using that now. And then if you do need a blood warmer, it would look something like this. The tubing will go through it and the blood is warmed as it passes through the tubing. All right, so that's what your blood warmer will look like. If you guys are ever in the OR, maybe you're doing cell saver or you're in the ER and they're rapidly transfusing your patient, they might have what the little warming packs and they wrap around the unit. They might do that in the OR or the ER when they are rapidly transfusing multiple units back to back, right? Because the units are very, very cold. So if they're rapidly transfusing that, we don't want our patients to go into hypothermic shock from the cold red cells, right? So that would be at a fast pace, multiple units at a very rapid pace. That you'll see ORs and ERs, and if your patient has a cold reacting antibody, that would be the use of a blood warmer. These blood warmers must be calibrated. They must be monitored, all right? So they must maintain a temperature. And so the nursing floor is responsible, or your biomedical engineering department, they're responsible for keeping record of that. And again, no microwaves, all right? And like we mentioned, vital signs are monitored during the transfusion, right before the transfusion, and then also when that transfusion ends, they'll take one final vital check. Like I mentioned, the most serious, if your patient's going to have a very serious transfusion reaction, it's going to occur within that first 15 to 30 minutes, all right? The first thing, and this will happen to you guys, if the nursing staff calls and says my patient spiked a fever or broke out in hives or is complaining of clammy skin, sweating, that's symptoms of a transfusion reaction. And we'll go more into depth when we start talking about transfusion reactions. The first thing you should always tell nursing staff is to immediately stop the transfusion, okay? And then they need to unattach the unit from the patient and remove the needle, all right, because we don't want the needle sent to us. We want the bag sent back to blood bank, all right? So we're going to culture that bag, especially if a fever spike was involved, all right? We want to make sure that the patient's fever was not due to bacterial contamination in the unit. So we're going to send that unit to micro for culture. And then we're going to repeat all of our testing. We're going to ask for a post sample, and we're also going to repeat the testing on our pre-sample. All right, patient ABO, RH, IAT, and then we'll also do a DAT as well. So whatever you do on the pre, you have to do on the post as well. All right, you treat them the same. And that's just to identify, maybe your patient had a JKA, all right? Typically that would be a delayed, maybe another one would be anti-D, all right? and maybe it was at undetectable levels. He received, for whatever reason, an Rh positive unit, and now he's having a transfusion reaction. We would detect that in our post sample. All right. Yes, ma'am.
Wouldn't your post sample also have possible different blood types? So they're a B and you're giving them O. Wouldn't you have a different front type reaction if half of their blood is wrong?
So if your patient was B and you give them O red cells, what's that going to do? They're going to have some donor cells in their circulation, so their front typing reaction with the B cells is just maybe going to be a little bit weaker, right? Yeah.
Be like a 3+ or 2+.
Right. Yeah.
Would that mean that their back type would be like 1 or 2+ because of the donor cells?
Their back type shouldn't change, because especially if you were just giving them red cells, their antibodies should still be there. Yeah. Now, if you had transfused like a lot of plasma, then you might see a difference in the back type. All right, so we talked about transfusion reactions. First thing to do is stop the transfusion, okay? And we will go more into this when we start talking about transfusion reactions as well. All right, so there are some special transfusion situations that you guys need to be aware of. And those include emergency release, neonatal transfusions, massive transfusion. Okay, what do you do if your clinicians want to, this is usually when your patient is actively bleeding out or has lost a significant amount of blood. They're gonna wanna, massive transfusion means that they want to give a lot of products at one time, okay? Those patients that have autoimmune hemolytic anemia and other disorders such as sickle cell and thalassemia, what are the concerns for those patients? All right, emergency situations. If your patient has a life-threatening hemorrhage, especially if you work in a patient or a hospital that has a ER and you have motor vehicle accidents, any type of traumas come in, massive transfusion might be initiated. Or it's a trauma situation and they want blood right then, they're not going to wait for you to complete testing. That is termed emergency release. In those situations, we usually always give O negatives. All right. If for some reason you are trying to save your O negative, if the patient is male, we can give O positive. All right. The concern is for females of childbearing age, we do not want to give them any, if they're Rh negative, well, in an emergency situation, you don't know. So you won't give them Rh positive at all, right, until their type is established. All right, so let me set the situation. Let me set the setting for you. You're in blood bank, ER calls, or maybe you have a emergency pager. Blood banks can have a pager. The ambulance services let them know when a trauma is coming to their facility. So your pager goes off, you know you have a motor vehicle accident coming in. If ER calls and say, hey, we want 2 units of red cells on this unknown patient, XYZ245, all right, then we don't have a sample. Blood hasn't even been drawn on that patient yet, all right? So we will set up 2 O negative units on unknown XYZ4567, all right? And then those are sent to the ER to be transfused. With that being said, and I happened to be in blood bank here at UAMS when this was installed, the ER now has what they call a blood safe. So they have a blood bank monitored refrigerator. So we monitor the temperature. It is linked to a computer in blood bank. So we know anytime that refrigerator is opened, anytime they open that refrigerator, it alarms in blood bank. So there are 4 O negative units kept in that refrigerator at all times. Nursing staff in the ER can access those 4 O negative units whenever they need it. There's a process they have to follow. They're supposed to have patient information, right? They have to enter that and then they scan the unit. So then we know that patient received that unit, right? And we have, remember those pilot tubes I talked about with the segments? We have those in blood bank. So once we receive the patient sample, we can cross match those units on that patient to make sure they were compatible. all right? So I remember being in blood bank when that blood safe was installed. You guys, it's scary, all right? Because the questions you filter from nursing, and then you're letting them choose what units are gonna be transfused. It was scary to let them have control of that, I guess.
Because you didn't trust.
I don't trust them, yes. But they're only O negatives, so, and then they didn't follow proper procedures, so then it involved a lot of backtracking on blood bank to track down those units when they were transfused, who did they go to. So don't be surprised if you guys do your internships here at UAMS, you'll get experience with that, and other hospitals might have that as well. Okay, so we have the situation established, and let's say maybe you do know who your patient is. Maybe they do have a name and medical record number for your trauma patient. If you already have an established history on that patient, that is not good enough, all right? You have to have a current specimen on file. So if you have your patient name and medical record number and you look them up and you're like, oh, I know they're O-pos. But until you get a current sample, we do not release type specific without a current sample, all right? What if they have told you it was the wrong patient? You have no proof that that's who they say it is, all right? So even if we know their history is O positive, we will still issue O negative until we have a current sample, all right? Does that make sense to everybody? Right, and so until your type is known, we will always give O red cells and AB plasma, okay? And again, don't ever try, if you're a patient, even if you don't know their ID, but you know they're a 27-year-old female, do not give them Rh positive, okay? And then once you receive that sample, you determine your ABO, then you can transfuse type specific, all right? Because then we know what their ABO is. We know if their IAT is positive or negative. We can cross-match units on them, all right? In blood bank, we will always try to give type specific. So if your patient is A positive, we will try to give them A positive or A negatives. If for some reason your patient has an antibody, then we might go outside of their type specific. We might go into the O group, all right? But usually we try to give type specific. Now, if you're AB, we're typically not gonna have any AB red cells on hand. So we will probably try to give you with A because there are more A donors than, and we're gonna save our O's, right? Because anybody can receive the O's, right? So we will try to give you A's. If you're AB, right? Does that make sense to everybody? We have AB plasma. Yeah. And we will hoard it. So the only time we will ever give it is in a trauma situation or to an AB patient. So we talked about that. All right, we talked about if there's not enough negative blood with the lack of donors, this is a common occurrence in blood bank. You might not have enough Rh negative blood, especially in a trauma situation if they're using a lot of products. All right, that's the #1 reason that we will switch over males to Rh positive, okay? So that's the emergency situation. The thing I want you to understand about emergency situation is oftentimes units are issued without cross-matching with your patient sample. When that happens, it is very important that you do what we call a post-cross-match. So once that sample is received, you will use those segments that were in your pilot tube. Those are your red cells. You will cross-match that with patient plasma, right, to make sure that it was compatible. Okay, that's called a post-cross-match. All right, so let's talk a little bit about neonatal transfusion, and this is from birth to about 4 months of age. This is actually one of the most transfused patient groups, and Oftentimes, if you work at a facility that has a NICU, you will do a lot of neonatal transfusion preparations. You guys finding vascular access is a concern for these patient populations, right? They have very small veins. We typically try not to stick them. And actually, it is noted that for neonatal transfusions, the most often reason for transfusions is iatrogenic, meaning that it was hospital acquired because we have pulled so much blood for them. Now we have to replace it. Right? It's usually for laboratory testing, anything like that, right? Because their volume is so much smaller at this age. Some reasons why we will give neonatal transfusions. That is to prevent the increased bilirubin, or to treat the increased bilirubin that is associated with hemolytic disease of the newborn, that we will spend a lot of time talking about in the next unit. And if you guys know, bilirubin can actually cross the blood-brain barrier. So if it does go to the brain, it can cause kernicterus, all right? And so that's one reason we can do transfusions or exchange transfusions. Maybe we pull off their blood and give them donor blood. Anti-D is the most common reason for this, all right? Especially for those mothers that do not seek prenatal care. Remember, because ROGAM can prevent the formation of anti-D. So if you have young females or any type of females that have multiple pregnancies and they have not had any prenatal care, then they most likely will have anti-D, and it is very detrimental to the fetus, all right? So the exchange transfusion or transfusion of neonates, it can lower the bilirubin, remove those fetal cells that have been coated with maternal antibody, all right? Therefore, the cells are not taken out by the spleen, okay? So it increases the cell survival. Right, we have already established that our neonates do not build antibodies until approximately 6 months of age, okay? So when you're dealing with neonates, we still want to make sure that it's compatible, right? So we usually will give, depending on what your facility's protocol is, typically for babies, we will give O negative and cross-match compatible with mom, okay? So we use mom's plasma. However, if your baby was delivered at another hospital and then transferred to the NICU at another hospital, we don't have mom's information, all right? So we would contact the birthing facility and say, hey, did mom have any antibodies? And then we would actually test baby's serum, all right? To just make sure that if there is an antibody in circulation, it came from the mom, okay? And that could be what's causing the baby's HDN. All right, so there's some attributes for all neonatal transfusions that you guys have to be aware of. For neonates, we will use the freshest possible blood available. Usually that unit must be collected within 5 to 7 days, right? And the reason for that is, remember we talked about as the storage of these units, as they sit on this shelf, the potassium is going to increase, all right? So we want it to be as fresh as possible to have the lowest amount of potassium. And also remember the T3-BPG also decreases as these red cells are stored. So we want to try to maximize the T3-BPG to allow for appropriate oxygen delivery in these neonates. And then we always want to try to use the CPDA anticoagulant. We don't want to use Adsol for neonatal transfusions. And if Adsol is all you have, then you will have to wash those red cells, okay? And it's just because the adenine in the Adsol is known to cause kidney toxicity, all right? And this just illustrates 90% of neonatal transfusions is due to that iatrogenic blood loss. All right, so it's the hospital. We draw so much blood from these patients so we can test them that it causes them to be anemic. Babies who have respiratory distress syndrome, so they need a higher amount of oxygen, they also will be transfused as well. It's just because their lungs are in stress trying to work. All right, so depending on your facility, you might do this 2 different ways. I've actually done this both ways. So when you prepare neonatal transfusions, typically you'll have your own negative unit, all right, that you choose for your patient, all right, your baby. You're actually going to put your baby label on this unit. And so this unit will stay with the baby for that 5 to 7 day period as often as he needs a transfusion, because we don't want to expose him to more allogenic donors than absolutely necessary, right? And so you'll notice that this unit is attached to several quad packs, all right? So depending on your baby's weight, and your clinicians will usually tell you, hey, I want 25 mils of packed red cells for this neonate. So you are going to, and this is already connected, so you will put this on a scale, and then you will hang your bag, and you will watch the amount of red cells go into your bag until you reach. We usually give them about +5 mils to allow for discarding in the tubing and everything like that. And then so once your scale reaches, then you can stop the flow of blood. And then in your computer system, you can divide this unit. And so it's usually like an A, B, C, D, however many satellite bags you have. Right? And you can actually use the sterile docker to connect more bags if you need to. So that's one way you could use the quad packs. I've also, at Baptist here in Little Rock, they actually sent red cells up in syringes. So you could attach a syringe to tubing, and then you could actually draw up 25 to 30 mils in a syringe, and then stick labels on that syringe, and that's how we issued it for the NICU at Baptist.
Does that change the expiration date?
It does not, because you're still using the sterile docker. You just have some all that extra tubing. And so this just says you can either use mom's sample for testing, all right? So if you want to make sure that unit is compatible, then you can use mom's plasma. If mom's plasma is not available, you can use baby. But you always want to contact where the delivery of that baby was to get mom's information, okay, to see if she has any known antibodies and what antibody it is. If mom has an antibody, that baby unit that you choose must be antigen negative, okay? So if mom does have anti-kel, which is the second most antigenic, we see it a lot too in HBN cases, that unit must be kel negative, okay? Right, so there's another requirement for neonatal. So we have fresh, 5 to 7 days old, CPD, all right, so no adsol. It also must be CMV negative. And I have told you guys about CMV negative before. Don't be surprised if some of your institutions no longer require CMV negative because they are doing leukodepleted, okay? Your babies are considered immunocompromised, so it's very hard for them to fight off CMV, all right? You and I, it's not really a concern, but for immunocompromised patients, transmission of CMV could be fatal to the neonates. And then, all right, so CPD, fresh, CMV negative or leukodepleted, and irradiated, all right, to prevent graft versus host. Again, because these are considered immunocompromised, all right? And we already mentioned the fresh cells. There's actually another requirement too for neonatal, and it is sickle negative. And you guys know moms are screened during pregnancy. So at about 28 weeks pregnancy, mom will have an ABO-RH done and an IAT. If she is Rh negative at 28 weeks, she will get an injection of RhoGAM, 1 dose, all right, 1 vial, if she's Rh negative, all right? And then she'll also, if she delivers an Rh positive baby, then she will also receive another vial of RhoGAM within 72 hours after delivery. Some of the institutions that you guys work at might actually do intrauterine transfusions, all right? So this is actually done through the umbilical cord while the baby is still in utero. They usually use CT guidance. They'll insert a needle into the umbilical cord. So it is quite an invasive procedure. This requires a lot of collaboration between blood bank and then the performing clinicians, all right? Because we need to have the blood ready. And as soon as that needle is in place, they're going to transfuse, okay?
Donate your cord blood if this is done?
So if you donate cord blood, it's not for this. So this would actually be like regular donor red cells doing this. And the reason for this is your baby might be in respiratory distress from that mom's antibody coating the cells. So the baby doesn't have appropriate oxygen carrying capabilities. So in an exchange transfusion or intrauterine transfusion, they will access the baby through the umbilical cord. Now, if you donate your cord cells, that is, you can donate it for research or you can have it stored for later, but that's to access the stem cells that's present in the cord blood. We will talk exactly how this procedure is done when we talk about moms and babies. But if you ever are involved in an intrauterine transfusion, it's very important that you use O-negative red cells because we don't know what the baby's type is at this point, right? We know what mom's type is, but we don't know what baby's type is. All right, so we will want to do O-negative and then make sure it's compatible with mom's plasma, all right? So whether you're doing a neonatal transfusion or a intrauterine transfusion, those requirements, fresh, CPD, irradiated, CMV negative, they all require, it's the same, right? All of those attributes must be met whether you're doing intrauterine or a neonate transfusion, okay? Okay, so massive transfusion. This is the beloved, every blood banker loves massive transfusion when it's initiated. Usually you'll have a designated phone line that is only for initiating the massive transfusion. In blood bank, it was a red phone, right? We had a red phone. When it rang, you usually have one specific person, right? And it doesn't have to be the same person every time. When I was in blood bank, we rotated. But one person who's on staff at that time in blood bank is the contact person for wherever they are, OR, ER, on the floor. All right, so one person talks to the clinicians. And in a ideal situation, you have one RN, one nursing person that you remain in contact with. All right, so you don't have multiple people barking orders, you don't have miscommunication occurring, it's that same people talking to each other. Right? And then, so if you are answering the phone, taking the order, and then you can say, hey, I need 4 AB plasma or 4, you know, if you have a type on file, you can use type specific, and 4 red cells and 1 platelet, right? So all of that is going to be issued at one time. So that's called a mega pack. 4 red cells, 4 plasma, 1 platelet. It's a 1-to-1-to-1 ratio, okay? And it's very important. So you keep track of how many mega packs are sent out. And as more mega packs are sent out, you want to make sure that they're monitoring the status of the patient. Make sure they're checking coagulation. That's a concern when your patient has lost so much blood and then they're receiving so many products. So make sure they're checking the PT and PTT, the fibrinogen. And if they have received about 2 to 3 mega packs, all right, so that's 8 to 12 red cells, 8 to 12 plasmas, 2 or 3 platelets, then you need to suggest that they give cryo, all right? Because remember, cryo is the sole concentration of fibrinogen. It's the only product that has concentration of fibrinogen, okay? It used to be thought that you would give 1 unit of FFP for every 5 units of red cells. Research has shown that is not appropriate. And so it is that 1-to-1-to-1 ratio, 4 red cells, 4 plasma, 1 platelet, okay? That will allow the patient to maintain their hemostasis most appropriately. So let's think about what's going on in a massive transfusion, those megapacks. You're given red cells for oxygen carrying capabilities. You're given plasma to replace their coagulation factors. You're given platelets, of course, to replace their platelets, all right? So they've lost blood, so they've lost the ability in their coagulation factors to stop the bleeding. They've lost the ability to adequately oxygenate their tissues. All right, and so that's the purpose of the massive transfusion, is to replace all of that. So that's why we need to maintain that state by monitoring their PT, their PTT, their platelet count, okay? And we talked a little bit about this as well. It's not uncommon. These products are going in at a very fast rate. I want you guys to understand that. They're rapidly being infused. They need to use a blood warmer to prevent hypothermia in those patients. There's always a risk when you transfuse patients because as blood is stored, the pH lowers, the calcium increases. However, when you're doing a massive transfusion, these patients typically have lost quite a bit of blood, all right? And so typically the risk of increased potassium and acidosis is not as severe as them not having their hemostasis, all right? So typically that's not a concern in massive transfusions, all right? And these products are going in so fast as well. And so remember, we talked about in our anticoagulant lecture, our blood collection process lecture, we talked about 2,3-DPG, how it decreases as these cells are restored. And usually, remember, the requirement for blood products is that 2,3-DPG can be established within 24 hours, all right? Studies have shown that it actually will start being regenerated about the 3 to 5, maybe 8-hour mark, all right? So that's the concern in massive transfusions as well. Giving them all these products, but is T3-DPG being regenerated to allow for oxygen carrying capabilities? Make sure there's nothing else I want to say about massive transfusion. And let's just hope if a massive transfusion protocol is initiated that it's not on a patient with an antibody, all right? If it is, let's say your patient does have an antibody and they're bleeding out. That is an example of when pathology needs to get involved. It is possible that they could give them antigen positive blood, depending on how severe they're bleeding out. All right, that's a call. Definitely want to get pathology involved. Definitely want to let the clinicians know this patient has an antibody. I don't have 4 units of red cells available right now. You're going to have to sign the waiver for uncrossmatched blood. Okay.
What happens during mass casualties?
In the blood bank? So I've actually never been involved in mass casualty, but they have a procedure in place in the blood bank. You would definitely have a call list. You call in more employees. Your donor center needs to be alert because you're going to need more inventory. Your ER is going to be triaging patients. And so there is a process, like everybody is going to be involved, and you would call in additional staff. All right, so let's talk about autoimmune hemolytic anemia. This would be like if your patient has a warm reacting autoantibody or a cold reacting antibody, causes a problem in blood bank. And I think I've told you guys, your cross-matchers are going to be incompatible. And so how do we transfuse those patients? Number one, we want to try to identify the cause, all right? Is it a warm reacting antibody? Blood bank will not recommend transfusion of a patient with a warm autoantibody, right? We're going to say transfusion is not going to do this patient any good. This patient's autoantibody is going to attack the donor cells. It doesn't really do them any good. Clinicians will disagree with you and they say, we're going to transfuse this patient anyway. So in these instances, we will give least incompatible units. And when we talk about compatibility testing, I'll mention a little bit more about the least incompatible. And so when I say incompatible, when we do our cross matches, we want our donor red cells mixed with patient plasma. We want that to give us a negative reaction, right? That lets us know in vivo that your recipient is not going to attack the donor cells, okay? So if you have a positive cross match, that means your cross match is incompatible. All right, so when we give least incompatible, when I say least, you want to try to give like a 1+ reaction, right? That's your least incompatible. All right, so that's what I mean by least incompatible. Most cross matches are negative, antigen negative, and then a negative cross match. Okay, if you have a patient with a autoantibody, your cross matches are going to be positive, right? And then so we try to pick the unit that is least positive. All right, does that make sense to everybody?
Would that be the clinician's responsibility after you don't recommend?
Yes.
Transfusion?
Yeah. And so blood bank is never going to, we're going to say transfusion is not recommended on this patient due to the warm reacting antibody, autoantibody. And then if they decide to transfuse, they have to sign a waiver saying that they're aware of the reacting autoantibody. So it takes liability away from the blood banker. All right, so there's two other populations of patients that get transfused a lot, sickle cell and thalassemia. All right, you guys remember with sickle cell, they have that abnormal hemoglobin S that forms the sickle cells. One of the reasons behind transfusion therapy for those patients is to remove the abnormal hemoglobin S, replaced with normal adult hemoglobin A. All right, so that's why these patients will receive so many transfusions. And when they're in sickle cell crisis, they might even undergo what they call an exchange transfusion. So based on your patient's weight, they will pull off so much of their own cells and then replace with the exact same amount of donor red cells. So we're pulling off that abnormal hemoglobin S, replacing with hemoglobin A, all right? And then thalassemia, because they have the globin chain disorder, then it replaces their oxygen carrying capabilities. You will see sickle cell and blood bank a lot more than you'll see thalassemia. All right, so the problems for these guys is they receive multiple transfusions over their lifetime. They will build alloantibodies, all right? And most of these guys, as you all know, they're African-American, so they have unique phenotypes. Usually they're Duffy A negative, Duffy B negative, Lewis A negative, Lewis B negative, and they'll usually have some type of Rh antibody, whether it be big C, big E. God forbid they have little e, all right? So the risk of alloimmunization, building those antibodies. There's a new protocol in place now. I think it was implemented probably about 7 to 8 years ago. When a patient is identified as a sickle cell patient, we try to establish what we call a baseline phenotype. And so we try to identify what antigens they are negative for, and then try to give them phenotypically matched transfusions. That way they are never exposed to a antigen that they don't have, therefore they can't build the antibody. That's just a new protocol that was in place maybe about 7 to 8 years ago. They try to do that now. So try to reduce the how often these patients are alloimmunized, okay? Sickle cells should always give leukodepleted products. Again, leukodepletion helps prevent febrile reactions due to HLA antibodies. And then a huge concern for these guys is because they do receive so many transfusions, they could have iron overload. So while we are replacing their abnormal hemoglobin S with hemoglobin A, they will also have increased iron storages from all of these transfusions as well. So it's very often that they will also have to have iron chelation as well. Your thalassemia patients will also receive a lot of transfusions. A new therapy that has recently been introduced for these patients is to use neocytes. So your donor is giving a colony stimulating factor to stimulate, so it might be erythropoietin, to stimulate the release of new cells from the bone marrow, and then they will donate. And it is those neocytes in the thalassemia patients that they can last longer in between transfusions. Right, so again, reducing the risk that, or the potential that they're exposed to multiple donors for that allo immunization. It's still a concern for them because of so many transfusions is that iron overload as well. So iron chelation might be used in these patients as well. All right, in your lecture manual, there is a portion that says instructions for infusion for the nursing staff. You guys can review that. It just goes over what gauge needle should be used, what type of tubing should be used, what type of solution should be run with the products, all of the typical questions that nurses will probably call and ask you. And depending on what you want your answer to be, you can say, well, you should have a SOP for that. You can refer to your nursing manual. All right, so we talked about some specific populations of patients that require some specific requirements for transfusion: sickle cell, thalassemia, our neonates, massive transfusion, and emergency release. Those are some special circumstances in blood bank that we always really want to pay attention to. All right, anybody have any questions? I think it would be really cool if I could stimulate a massive transfusion. Maybe we could do it in lab one day. I would love to do that. So,
I have a question. Yeah. So when are we giving the baby the kind of blood? Is it like blood?
It is.
Okay.
Yeah. So it's just your regular donor blood, but it has to be fresh, and it usually is O negative. Depending on your facility's standard operating procedure, if you have a policy in place that says you can give, if you're doing a neonatal transfusion and the baby is Rh positive, then you can give O positive. But your lab has to have a procedure for that. But otherwise, it's just O negatives. And that's why if any of you guys are O negatives and you donate, the donor center will usually harass you. Because number one, O negative is the universal donor. It can go to anybody. And then number two, babies can use that as well.
So big eye and probably would be.
No, typically not, because what would be the concern is if they already had anti-eye, and then they're not going to build that until 6 months of age. So it's not a concern.